The oral presentation, which will be presented by budding clinicians and researchers. To chair this session, we welcome Dr. Priyankar Pal and Dr. Sajay Philip on the dais. Dr. Priyankar Pal is the professor and head of the Department Pediatrics, Unit Head of Pediatric Rheumatology in the Institute of Child Health, Kolkata. He was the past president of Pediatric Rheumatology Society of India and the past president of Indian Society of Kawasaki Disease. Dr. Sajay Philip is the founder president of Kawasaki Disease Foundation of India and Indian Society of Kawasaki Disease. He is now the clinical and administrative coordinator of Dr. K.M. Cherian Heart Foundation, Parumala, Kerala. His expertise is on Kawasaki disease and fetal cardiology. So the first session would be oral presentation. We have 6 speakers lined up. So each speaker would be given a time of 5 minutes for the presentation, and there would be 2 minutes for question and answers. Each presentation would be timed. So we invite the first speaker, Dr. Vibhu Joshi.
Good morning, everyone. I'll be presenting my PhD thesis work on expression of Fc gamma receptors in Kawasaki disease, pre and post immunoglobulin therapy. So as we all know, Kawasaki disease is a medium vessel vasculitis. The etiopathogenesis is unclear and is thought to be a complex interplay of genetic factors, infections and immunity. IVIG is standard of care, and high dose IVIG provides prompt anti-inflammatory effect. However, the exact mechanism of action is not clearly understood. The Fc region of IgG mediates its effective function and binds with Fc gamma receptors. These are the family of Fc gamma receptors, amongst which all are the activatory receptors, while only one, CD32B, which is Fc gamma receptor 2B, is inhibitory receptor. Altered Fc gamma receptor expression can lead to complications like development of coronary artery aneurysms. So genome-wide association studies have identified Fc gamma receptor 2A as a susceptibility locus, and subsequent studies have shown that non-allelic homologous recombination has resulted in copy number variations and noble chimeric genes, resulting in aberrant functional expression. However, there are no detailed expression studies for patients with Kawasaki disease. So there are challenges in immunophenotyping of Fc gamma receptors due to the high sequence homology. It is difficult to dissect the subsets of Fc gamma receptor 2, and moreover, Fc gamma receptor 2C is a pseudogene. So the study design involved acute KD patients, and subsequently post 36 to 72 hours of IVIG, the samples were, these were resampled, and the surface expression of these Fc gamma receptors was done. So this was the staining protocol, and using flow cytometry, the surface expression was seen on lymphocyte, monocyte, neutrophils, B cells, T cell, the subsets of monocytes. And this is how the surface expression looked in control, pre-IVIG and post-IVIG. The surface expression of the delta median MFI of Fc gamma receptor 1 on neutrophils was significantly increased in patients with acute KD prior to administration of IVIG. While for the Fc gamma receptor 2A, the delta MFI decreased post-IVIG, and for Fc gamma receptor 2B/C, it was decreased before administration of IVIG compared to control, significantly decreased. However, the inhibitory receptor increased post-administration of IVIG. Similarly, for the expression of Fc gamma receptor 3A, it was significantly decreased in acute patients, and Fc gamma receptor 3B also was significantly decreased in acute patients compared to the control. So the consolidated results of acute KD versus control, these showed that the Fc gamma receptor 1 on neutrophils was significantly increased compared to the controls. Fc gamma receptor 2B was significantly downregulated compared to the controls, and Fc gamma receptor 3A and 3B were significantly decreased compared to the controls. On comparison of pre-IVIG versus post-IVIG, the Fc gamma inhibitor receptor was significantly increased after administration of IVIG. However, the activatory receptor 2A was significantly downregulated in post-administration of IVIG. So, our hypothesis confirms that the activation of activatory receptors decreases following IVIG. Which can be seen in the picture that the activatory receptors they get internalized and degraded and hence decrease post IVIG. However, the activatory receptor they get recycled back to the surface to be available for another round of signaling. And these results were also confirmed by a confocal study by Zhang et al. The clinical applications of the study were that the recent literature had shown that immunophenotyping of Fc gamma receptor expression on leukemic cells using peripheral blood, which is rapidly available and improves risk stratification in acute myeloid leukemia. Similar studies also were shown in responses to rituximab in patients with rheumatoid arthritis and SLE. Our study in KD suggests the potential utility of immunophenotyping of Fc gamma receptors to be helpful in assessing response to IVIG and may serve as prognostic and diagnostic marker in KD. I would like to thank my co-guides, all the consultants, fellow PhDs, postdocs, research fellows, senior residents, and DST Inspire for the fellowship support. Thank you.
High dose for IVIG sometimes it can saturate and block receptors. So is there any problem for you to quantify the receptors after the IVIG?
Sir, initially we did not realize this fact, but then we changed our strategy and we blocked the receptors with inhibitory receptor first so that we could get the specific expression. So this was a strategy in which we initially blocked the unwanted non-specific Fc receptors. Then we gave the specific staining with the inhibitory receptor for half an hour so that we get the specific results for inhibitory receptor. Then we washed the cells again and then stained with rest of the activatory receptor and rest of the antibodies to be more specific.
And this surface expression is all receptor 2B all included or
Sir, it was difficult to dissect all the receptors because of the sequence homology between these receptors. So we had dissected the 2A into 2A, 2B. However, 2B and 2C could not be distinguished because of the fact that 2C is pseudogene and only expressed in some patients with certain allelic variations. It's not present in all cases and controls.
One or two points for the clinical application in KD cases.
So we had also segregated these patients on basis of their response to IVIG and on the basis of coronary artery involvement. So our sample size is low to conclude the fact that however we have hypothesized that we will be able to predict whether this patient will respond to IVIG or will not respond to IVIG so that the alternative therapy can be started on time to prevent aneurysms in the patient.
So you have mentioned from the leukemia study that it's pretty fast. So how rapid is the, because we are, what I understood that we can understand the IVIG resistance of this drug. So how rapidly can you get it?
So the test results are available as lymphocyte subset only. Overnight we can provide the surface staining results.
So within 24 hours?
Yes, yes. But we had kept the IVIG resistant time point as we had taken the specific time point according to AHA as 36 to 72 hours. So yes, the results can be available overnight.
So some of it adds to the clinical.
Yes. Thank you. Thank you.
For the second presentation, we have Yeah, no. Next, yes, sir.
A very good morning to all present. I would like to present our experience at the All India Institute of Medical Science with respect to giant coronaries in children with Kawasaki disease. So, as we all know, coronary artery abnormalities are potentially fatal complication of Kawasaki disease, with 17% of the patients developing the same, with giant aneurysms as frequent as 3.1%. We know that they regress, and there are factors which predispose and decide who regresses and who worsens, and patients who would require adjunctive therapy. In our practice, we encountered 5 out of 34 children in the last 5 years with giant coronary arteries. So the first case was that of a 24-month-old boy. He presented to us with fever, hand dorsum edema, desquamation, and conjunctivitis. A provisional diagnosis of incomplete KD was made, and IVIG was started. A coronary echocardiogram was obtained during this period, and we found a giant aneurysm of the LMCA. The therapy was intensified primarily with infliximab, and that is when the patient presented to AIIMS. So we were monitoring the patient, and the second half aliquot of the infliximab was ongoing, and we noted that 4 days into therapy, his coronary aneurysm had arrested in progress, and he was monitored and discharged on aspirin, enoxaparin, and atorvastatin. At recent follow-up 6 years post, he persists to have giant coronary artery aneurysms, but is clinically stable and is able to lead a normal life. The other case was that of a 60-month-old boy who presented again with incomplete Kawasaki disease and was found to have giant coronary aneurysms and was referred to us at day 8 of illness. IVIG therapy was started, and the patient was intensified primarily with infliximab and also supported with oral steroids. Echocardiographic follow-up showed a persistent coronary artery aneurysm, in fact, an initial bursting. However, subsequent monitoring showed some regression. He was discharged on aspirin, enoxaparin, and statins, and he's doing well 3 years post follow-up. The third case was that of a 6-month-old boy, a young infant with fever, conjunctivitis, and rash. He'd been treated outside at day 30 of life when he was screened suspecting in hindsight Kawasaki disease. He was found to have giant coronary artery aneurysm. Sizes were not documented. And for multidisciplinary management, he was referred to AIIMS, New Delhi. We confirmed that he had giant coronaries, and there was no fever, no inflammatory markers. So we decided to support therapy with aspirin and antiplatelet agents and to follow the patient. 6 years into this, he's doing well. The fourth case was that of a 8-year-old boy. He presented again with fever, edema, and desquamation, a little outside of the range of age that we expected him to be. He had elevated inflammatory markers and giant coronary arteries. Z scores were available from outside and not the absolute sizes. He was started on IVIG in the emergency and was primarily intensified. We did a repeat echocardiogram which had confirmed the giant coronary artery aneurysms. Once the disease had deafest, we discharged him on beta blockers in view of LV dysfunction that we had found during our management, and warfarin, enoxaparin, and atorvastatin. He's 7 years into follow-up and doing well, going to school. The last case was a little atypical. It was that of a 5-month-old girl. She'd been febrile for 10 days, and the parents characteristically complained that she had fast breathing and diaphoresis, and some swelling that had developed in the bilateral axillary region. On evaluation, the picture was similar to KD, except for the swelling in the bilateral axilla, which was a little atypical. She had been treated with multiple oral and IV antibiotics. On arrival at AIIMS, we screened her coronaries and found that she had dilated coronaries, and IVIG was started pending admission. The axillary swelling was pulsatile, as is appreciable, and bilateral. An echocardiogram confirmed dilated coronaries with aneurysmal LAD, dilated descending thoracic aorta on Doppler, and subclavian and axillary axis also being involved, with a dilated common femoral artery as well. We intensified our therapy primarily with IV methylprednisolone and infliximab, and ultimately had to transition to steroids because the patient had persistently elevated markers, active fever, and a pulsatile swelling, persistently enlarged coronaries. So the patient was under monitoring. We also did a volume rendered computed tomography for this patient and found that there was aneurysmal involvement of the right coronary artery, left anterior descending, left circumflex, in addition to the systemic vascular involvement of the subclavian, aortic, and the femoral axis. Ultimately, the patient passed away, likely due to coronary rupture. There was no visible impression of hemoperitoneum, but the patient did have aortic aneurysm and was under consideration for an intervention by the CTVS and the cardiology teams. However, she could not be salvaged. So to summarize, we had 5 cases, one of whom did not make it. All of them were incomplete KD, but did not pass the cutoff of the Kobayashi score. That is, they were all less than 4. So our observations were in line with the available evidence. Incomplete KD may have a high propensity to develop giant coronaries, possibly refractory to immunomodulation, and delayed diagnosis and immunomodulation are important factors determining the prognosis. Although rare, systemic arterial aneurysms may be life-threatening despite immunomodulation. Thank you.
In some of the cases, you put in the bracket that is Z-score,
Yes, sir.
and the 6 months old case,
Yes, sir.
giant errors you mentioned, but measurement not mentioned.
Yes, sir. That patient was referred to us from outside and they did not mention Z scores and they could only write dilated coronaries. Since this is retrospective data, there is that limitation and I acknowledge that. Once we entertain the patient in the ER, with our facilities there, we are able to discern dilated coronaries, but for accurate sizing, we have to take them to the CNC, the cardiovascular building. That takes some time, but we start therapy pending the same.
Out of 4 cases, one case received beta blocker.
Yes, sir.
In your follow-up, have you noticed any regression of the aneurysm in the beta blocker case?
So there is non-progression. We would not be so bold as to say that there is regression, but there is definite non-progression.
In the beta blocker, they are added for non-aneurysm, the giant aneurysm cases.
Yes.
And I really appreciate your pictures again stating that there is a definite echocardiography limitation.
Yes.
CT is necessary to
Yes.
see all the generalized aneurysms.
Yes, sir. But for case number 3, we did CT for all our patients, and I could not include them for paucity of time. But this case was quite striking. The axillary aneurysms were not expected by the referring physician, and it was a high index of suspicion by the ER team that this might be a part of Kawasaki. So I would like to acknowledge them also in the same. No, sir, no major adverse cardiac events so far. They are doing day-to-day activities but not participating in contact sports. Sir, all of them had to switch to warfarin, and we are running into trouble with the anticoagulation. We are jumping our INR targets. So that is the affordability for inoxa is a definite problem, and DOACs are not commonplace use, although cardiologists seem inclined to shift to them in coming future. Statins are being given routinely at our center. That is their in-house protocol.
So it's just, I think because it was a referral center, the number of cases
Yes.
were a little
Yes, sir.
compared to the total number of cases.
Yes, sir. We had 14% and 34. The number itself is low. During COVID also we saw more MISC dilated coronaries rather than KD. And because of the referral center bias, maybe we're getting a lot of giant proportion. We got 14% as opposed to literature reported 0.15 to 3.4%. So, but that enhances our experience in managing these cases.
And none of the children had any traumas.
No, sir, none of the children had any thrombus. They were actually many a times pre-treated before referral. The treating physicians, they were not able to manage cardiological interventions, but for the same they referred and they added some kind of antiplatelet anticoagulant so that the children would not develop thrombus. So we had an informed referral pattern as well. Maybe Delhi has that facility. So patients came to us mostly in a state where they did not have a thrombus. 5 out of 5 actually. Thank you so much, sir. Good day.
Thank you, Mr. Ambedkar. The next presentation we have Ms. Neha Ghosh.
Next, please.
Good morning, everyone. I am Dr. Riya Ghosh. I'll be presenting on case report on autoimmune shenanigans, so the SLE and Kawasaki disease crossover. I would like to give thanks to my guide, Director and Professor Dr. Dionath Mahato, Professor Dr. Anu Maheshwari, and Professor Dr. Shamit Gulati. So SLE is a multi-system autoimmune disease with a multifactorial pathogenesis presenting with varied symptoms that may be challenging to diagnose and tends to have a more aggressive course in children than in adults. Kawasaki disease is a self-limiting febrile illness causing inflammation in medium-sized vessels, especially the coronary arteries, and it is the leading cause of acquired heart disease in children. Peripheral gangrene is, however, a rare manifestation of the Kawasaki disease. However, it is a relatively more common presentation in SLE, as both SLE and KD share the same etiological factors and both have multifactorial etiology, with autoimmunity considered as one of the important etiopathogenesis. So we report here a case of 13-year-old girl presented with dry digital gangrene and self-amputation of digits. The gangrene raised suspicion of vasculitis, while a 2D echocardiography revealed coronary vessel dilatation with aneurysm, suggesting a possible overlap of SLE and KD. So case report, a 13-year-old girl presented with a 1-week history of high-grade fever, which subsided with antibiotics, followed by which she developed blackish discoloration of her fingers and toes for 10 days, along with a burning sensation in both upper and lower limbs. She also had a significant past history of similar symptoms, leading to self-amputation of a digit and toe a year ago. There were no symptoms of redness of eyes, hair loss, seizures, behavioral changes, Raynaud's phenomena, oral ulcerations or arthritis, rash, photosensitivity, weight loss, anorexia or hematuria prior to this presentation. So on examination, as you can see, there are gangrenous changes were noted in digits of both upper and lower limbs. BP was measured 140 and 110. It was hypertensive with no significant difference noted in forelimb BP. Peripheral pulses were variable, bilateral radial, brachial, femoral pulses were of low volume, and peripheral pulses like dorsalis pedis, anterior tibial and popliteal were also low volume. So the investigations were done keeping in mind the diagnosis of vasculitis. So anemia on differential counts, anemia, leukopenia, however normal platelet count was present. ANA by IF titer was 1:80 and diffuse pattern. Anti-DS DNA was more than 400 international unit per ml. C3 and C4 level was low. P-ANCA and C-ANCA was negative. APLA was negative and DCT was negative. However, ESR was raised. QCRP was raised. CECT angiography of upper limb and chest was done. Right distal radial artery thrombosis at the level of distal radius. Thrombosis of right cephalic vein was present. And there were some features suggestive of pulmonary artery hypertension. Bilateral pleural and pericardial effusion was there. CECT angiography of lower limb was done. Non-ossification of right distal dorsalis pedis artery was present even on the venous phase. Considering that the child fulfills the criteria of SLE, diagnosed as SLE, however, considering the possibility of vasculitis presenting as gangrene and the rare presentation of Kawasaki disease, a 2D echo was done which revealed coronary artery dilatation. Moderate pericardial effusion of 13 mm, LMCH score plus 2.9, LAD was plus 3.3 and RCA plus 1.23. So working diagnosis is kept SLE overlap with Kawasaki disease. Child was given IVIG at the rate of 2 gram per kg over 12 hours with aspirin 4 mg per kg per day. For SLE, hydroxychloroquine was started at 5 mkd and discharged on oral prednisolone and hydroxychloroquine. Following the treatment with the IVIG and aspirin, patient has shown the improvement. So to the best of our knowledge, or so far only 3 case reports of the overlap between SLE and Kawasaki disease have been published. So these are the cases. One was published in 1988, another 2012, another in 2016. Here you can see the first case, KD, was followed by SLE 3.5 years later, and there was features of serositis and coronary artery dilatation. ANA and dsDNA in 3 of these cases were positive, and they were treated with IVIG and aspirin followed by methylprednisolone pulse. However, in the third case, they were given as IV cyclophosphamide, keeping in mind the diagnosis of lupus myocarditis. all of these cases have on follow-up on 2D echo, the size of coronary artery diameter was decreased. So, conclusion that coronary artery vasculitis and gangrene may manifest as Kawasaki disease in the background of SLE. Both conditions as they share overlapping triggers, making KD possible in SLE patient. Although ANA have occasionally been reported in children with KD, a diffuse pattern of ANA along with a very high titer of anti-dsDNA antibody and positive ANA antibodies are strong pointers towards SLE. The child may have had undiagnosed KD a year ago, leading to coronary artery dilatation and gangrene. Improvement in coronary artery diameter after IVIG treatment that supports our Kawasaki disease diagnosis. So given the concurrent autoimmune process in both SLE and KD, symptoms may present more aggressively, increasing the likelihood of misdiagnosis. So KD may be missed in SLE cases as IVIG is not a standard treatment protocol for SLE. Thank you. So these are the references. Thank you.
Why not just a lupus? So what is the cardiac involvement in lupus?
Sir, in the lupus, there could be lupus myocarditis, there could be involvement of like Liebman-Sack endocarditis can also be there. But compared to Kawasaki disease, this involvement like of coronary arthritis or coronary artery dilatation is however rare. So we kept a diagnosis of Kawasaki disease initially in the background of SLE.
Lupus is basically kind of
Pancarditis, yes, sir.
and your patient has significant
Yes, sir. Severe pericarditis.
So, and the coronaries were not cross-dilated. These goes around small aneurysms, let's say.
Yes, sir.
You would consider it more of a...
So it was more of a background of SLE that, however, it can be there with Kawasaki disease. So more towards.
It was negative, antiphospholipid was negative.
Yes, sir.
So what is seronegative area? What about seronegative factor?
Sir, I don't remember exactly right now.
Any criteria has been fulfilled for KD disease other than coronary?
No, sir, only the fever was present. However, there was no disformation, no behavioral changes. So we can keep that as a diagnosis of atypical KD. QCRP level was, sir, high and ESR level was high. Because, sir, in adolescent age group, the atypical presentation is more common in Kawasaki disease. So we kept that other differential diagnosis in this case.
We think that the criteria, at least 2 or 3 criteria has to be fulfilled in favor of KD, the than coronary involvement. Because many diseases can get the vasculitis, like beta-carotic arthritis, many overlapping diseases. Even dengue also can overlap, but criteria has to be fulfilled. If it is not fulfilled and coronary only involvement, then still, as Dr. said, more in favor for SLE presentation.
So the
Then you consider only gangrene
gangrene and coronary artery dilatation involvement is there. Okay. Thank you, sir.
Thank you, Mr. Yakush. For the next presentation, we have Dr. Sonjali Raha, who will be presenting the clinical case.
Next laser बताइए.
A very good morning to all. My case presentation title is Nailed by the Nails, Kawasaki disease missed in the acute phase, unmasked by Bewes lines. So as we all know, Kawasaki disease is the commonest childhood vasculitis and is the most common cause of acquired heart disease in children, predominantly affecting children below 5 years of age. Diagnosis of KD is clinical with no pathognomonic laboratory investigation, and investigations support the clinical findings. Hence, a significant proportion of KD cases are missed or are diagnosed late. Now, several types of nail changes have been described in patients with KD, mainly during the convalescent phase. Though they are not in the diagnostic criteria, they can often help in reaching the crucial diagnosis. Hence, the importance of physical examination can't be emphasized more, and this fact will be highlighted in my case. So today we have a 4-year-old boy presenting with fever for 5 days in the month of December 2024. So the child had presented to us with daily high-grade intermittent fever spikes for 5 days that was associated with dry cough. Now on probing history, we found that the child had actually been symptomatic for the last 6 months, from August 2024, when he had high-grade intermittent fever spikes lasting for 6 to 7 days at a time, and 3 such episodes in August 2024. From September to October, the child had daily high-grade intermittent fever spikes that had lasted for 20 days duration. Now during this time, he had visited multiple healthcare professionals, had been treated on the lines of upper respiratory tract infection, and had received multiple courses of oral antibiotics. At the same time, the child had rash, which was non-pruritic erythematous rash, starting from face and progressing to entire body, lasted for around 11 to 12 days and had weaned off, and this was followed by skin pilling that had again weaned off by beginning of November. The child also had a single grape-sized swelling on the back of the neck on the left side, along with redness of eyes, which was non-purulent and had lasted for 5 days. The rest of the history was non-contributory. The child belonged to an upper class in socioeconomic status. In examination, vitals were within normal limit and anthropometry was well preserved for the child. The child was alert but was significantly irritable at the time of examination. The salient points in general physical examination include edema that was noted over the dorsum of hand and in feet. We can also note Bewes lines and chromonychia here, which is highlighted in the next slide. So Bewes lines are basically transverse depressions like this across the nail plate, which signifies systemic disruption of the nail matrix. They are not specific to any particular diagnosis, neither they are specific for KD. However, in the presence of a clinical scenario and a history and physical examination, Bewes lines can place one diagnosis over the other. So the presence of Bewes lines made the KD high on cards in this case. The rest of the systemic examination was within normal limits. So with this history and physical examination, a diagnosis of Kawasaki disease was missed Kawasaki disease was made. So we went on going on to the laboratory investigations for this child. The only significant finding here is a pro-BNP elevated and a mild level of anemia present in the child. Coronary artery imaging showed dilatation. The echocardiographic findings showed dilatation in all the coronaries. However, a CT coronary angiogram that was done later showed a dilatation in the left main coronary artery, and the rest of the coronaries were normal. So this is the CT coronary angiography finding for this child, which shows a fusiform dilatation in the left main coronary artery. So the child was subsequently treated for Kawasaki disease. The child received IVIG 2 gram per kg on day 1 of admission, followed by methylprednisolone pulse for 3 days and continued on oral prednisolone. He was also started on cyclosporin and received infliximab on day of admission 3. For giant aneurysm, he was started on aspirin and low molecular weight heparin and was discharged on these drugs. He continues to be on our follow-up. Currently, he is only on aspirin. The immunosuppression has been weaned off, and he is currently doing well. The repeat coronary angiography findings show a reduction in the size of the aneurysm. So the message from today's presentation is a variety of nail signs have been described in Kawasaki disease, though they are not part of the diagnostic criteria. Bewes lines are transverse ridges on nails signifying systemic disruption in nail matrix. They are not specific for any particular disease, and they are seen in the convalescent phase of Kawasaki disease. A thorough clinical examination and a high degree of suspicion is essential to clinch the diagnosis of Kawasaki disease in many cases. More awareness is needed among referring centers to pick up the disease in the acute phase and prevent devastating complications. Thank you.
You given IVIG and followed by infliximab during the convalescent phase?
Yes, sir. But this
inflammatory markers were very high.
It was not high, sir. But we gave because the child had already developed aneurysms by this time. So IVIG we gave, and then since he is 4 years of age and giant coronary aneurysms were already present, so we gave followed by IVIG the other end.
Just for your satisfaction. So we understood that the inflammatory markers are not high.
Not high, sir.
Settled. Then no point of giving the IVIG.
So the slide of the progress curve, you have a slide, you can see the also, A1, A2, A28. So what is impressive, I will say that is treated the child almost after 2 months.
Yes,
So
sir.
if you consider that the time of occurrence
Yes, sir.
around October, because
September, October, and we December maybe we have treated.
So for almost 2 months. And we know that both lines also come after at least 3 weeks.
Yes, sir.
Around 3 weeks of both lines are here. So even late with normal inflammatory markers, but there was some improvement.
Yes, sir.
Hiking of the management. I think that should be the
Yes, sir. So it has reduced, and further after this was around January, this CT coronary angiography could have been done. And then in February, the repeat echocardiography has been done. That shows a medium level dilatation currently.
That means after 3 months.
After 3 months almost.
So that may be like a natural course of research.
Yes, sir.
I don't think so, because as far as we understood that the inflammatory markers are high, definitely we are going to be.
thank you.
Yes, sir.
Next speaker will be Dr. Yasin.
Next. Yes, sir.
Good morning to one and all. I'm Dr. Riya Singh and I'll be presenting a case of thrombosis with multiple coronary aneurysms in infantile Kawasaki disease. As we all know, Kawasaki disease is an acute systemic vasculitis that involves coronary arteries in young children, and even though giant aneurysms are rare, they can be complicated by thrombus formation, leading to myocardial ischemia, myocardial infarction, and even death. So, this is a 9-month male infant who presented with high-grade fever for 11 days with transient erythematous rash and red eyes on day 3 to 4 of fever. He was diagnosed as incomplete Kawasaki disease. On blood investigation, it showed high TLC count with 15,800 neutrophilic, platelets were 9.5 lakhs and raised CRP with 123 milligram per liter. Echo showed giant aneurysm in LMCA with Z-score of 12.6, medium aneurysm in LED and RCA with Z-score of 6.7 and 8.4 respectively, and there was a thrombus at LMCA bifurcation measuring 4.6 to 3.5. This is an image showing LMCA with large thrombus. So, the child was diagnosed as incomplete Kawasaki disease with multiple coronary artery aneurysm with a thrombus in LMCA and was initiated with treatment with IVIG, infliximab, aspirin and low molecular weight heparin. And daily echo was done. In our serial echo after 4 days showed a new thrombus in LAD in spite of the treatment. So, the treatment was intensified with oral cyclosporin and clopidogrel. This is an image showing thrombus in LMCA and LED. So, on day 1 of diagnosis, there was a giant aneurysm in LMCA, medium aneurysm in LED and RCA with a thrombus in LMCA. On day 3 of diagnosis, the Z-score in LMCA and LED increased, leading to giant aneurysms, and RCA showed medium aneurysm. And the thrombus was almost same in size. But after day 4 days of this echo, on day 7 of diagnosis, there was another thrombus in LED measuring 6 mm by 4 mm. So at this time, our treatment was intensified with oral cyclosporin and clopidogrel, and on day 20th of diagnosis, the LMCA aneurysm reduced to medium size. Medium size aneurysm was still present in LED and RCA, but there was no thrombus in the lumen. So the outcome of this by day 20 was that there was resolution of both thrombi. The giant aneurysm in LMCA and LED reduced to moderate size, which was later corroborated by CT-CA after 6 weeks. Last follow-up was done 7 days back after 5 months from the onset of the disease, which showed LMCA having small aneurysm with Z-score of 3.5 at bifurcation, and all other coronary sizes were normal and lumen was free of thrombus. The child was managed intensively with IVIG, infliximab, cyclosporin, dual antiplatelets and low molecular weight heparin, and echocardiography was done daily initially for 10 days till stabilization of the thrombus size, and then alternate days till resolution of the thrombus.
So we conclude that frequent echocardiographic monitoring during the acute phase of KD helps in early detection of complications like progression in size of the aneurysm and formation of the thrombus. Timely aggressive management can lead to dissolution of the thrombus and also regression in the size of the aneurysm. So I would like to end this presentation with a question that can we consider treat to target in KD? Thank you.
So this child as infant, 11 months old infant, presented on day 11 with a thrombus.
Yes, sir.
So would you consider this thrombus to be a little early?
Early thrombus, yes, sir, because it is known after 2 weeks of the illness, but it is on 11 day, within 2 weeks of the illness.
Do you have the monitoring facility for the factor X?
No, sir. Yes, sir. Yes, sir, but we don't have that facility.
Early thrombus formation is
Thank you, sir.
Next presentation is by Dr. Harun.
ये ना प्रेजेंटेशन है आर्टिफिशियल इंटेलिजेंस आगे कैसे होती है स्लाइड इसमें ये नेक्स्ट है लेजर
Good morning, everyone. My name is Harnoor Sidhu, and I am fifth year student of Doctor of Pharmacy in Adesh University. So I am the youngest of everyone present here, and so my topic is artificial intelligence in Kawasaki disease. So Kawasaki disease is an acute febrile systemic vasculitis, also known as medium vessel vasculitis, because it mainly affects coronary arteries if left untreated. Untimely treatment or late diagnosis may lead to coronary artery aneurysm. There are 20 to 25% chances of CAL. KD impart high risk in male gender compared to female. The incidence of Kawasaki disease is highest in East Asian countries, moderate in USA, and low in Europe, variation based on the ethnicity. In India, the recent reported data on the incidence of KD is 8.89 cases per 1 lakh patients, 1 lakh people. So these are the clinical features. Fever, that is the main feature, persistent for 5 days and followed by conjunctival infection, bilateral and exanthema, lymphadenopathy, mainly unilateral, changes in the lips and oral mucosa, also called as pink tongue and dried, cracky lips, changes in the hands and the feet. So these are the laboratory findings. So Kawasaki disease in special situations such as in infants, in older children, mainly represent in form of myocarditis, atypical Kawasaki, and may be associated with infection or sepsis. So it is really important to diagnose it carefully and don't so that we can treat KD appropriately. So why AI in medical sciences? It can improve the patient care and workflow efficiency. drug discovery due to the vast data analysis, professional assistant to the medical clinicians so that they can do efficient diagnosis and prognosis, personalization of drug therapy, and contact tracing for disease control measure. As we have seen in COVID-19, it is the main feature of AI. So why AI in Kawasaki disease? Early diagnosis and acute diagnosis, because there are many clinical conditions that may show the symptoms of Kawasaki disease. So AI can help to analyze the patient data, lab results, and imaging to help doctors to differentiate KD from similar conditions, reducing the diagnostic errors. Predicting IVIG resistance. We all know that IVIG and aspirin are the only medicines that we can fully rely on the treatment of KD. If we can predict the resistance, so the clinician can start the robust anti-inflammatory therapy early on in the therapy. So risk stratification of coronary artery complications. AI can assess the echocardiogram and the lab result to predict which patients are the high risk of developing coronary aneurysm. Personalization of treatment plans, enhancing imaging interpretations, and reducing the healthcare burden by automating the data analysis, predicting disease outcomes, and optimizing resource allocation. So this is the basic thing that AI can use, that is preventing the coronary artery aneurysm by enhancing the diagnosis so that early condition can be identified in the patients. So these are some tools according to the recent articles that are published. I have collected all the tools that are used. These all diagnostic tools have high specificity according to the research article that the researchers have published. So the difficulties in using AI are the accountability and liability, and the need for regulatory frameworks to define the role of clinician, developers, and the institutions. So reproducibility and reliability. The data should be collected across the diverse population and the healthcare setting. Standardized protocols for benchmarking and assessing AI performance are essential. Ethical and legal consideration. Patient data privacy must be ensured with strict anonymization and security measures. AI should use only essential medical data following legal and ethical guidelines. And AI models trained on large data sets from different hospitals must perform consistently, ensuring AI is robust and adaptable to various clinical environments. So this is the conclusion. There are several additional possible uses of AI. The data, so the main thing with AI is the data. The data should be collected from the multiple institutions so that an effective AI algorithm should be implemented so that the diverse population patients can be treated accordingly. And also they should meet the ethical and legal requirements. So the way that the individual with KD are treated and get medical care will be more enhanced with the involvement of AI. Thank you. This is the reference.
This is your just a proposal, or have you tried this in practically?
Sir, no, I have not tried it practically. This is basic review of all the AI tools that are available and which have high specificity and selectivity for treatment of Kawasaki.
I did a project on hormone converting to phonocardium, and by deep learning technique, computer will say this is VSP,
Yes, sir.
he published also 3 papers. Saying that it is not really as easy because you have to keep a deep learning technique for all the scorings, for example, some score, then science and symptoms, laboratory parameters, everything has to be to the software people has to help you for deep learning. And then we have to give a trial that the computer will interpret the problem. Now itself, with one criteria and two criteria, BT plus again.
Okay, sir.
I don't know that is possible. Is here now. Yeah, can you some comment that is possible with the deep learning technique?
Yeah, actually, both the deep learning and machine learning. I'm Dr. James Stefan. I'm an associate professor in electrical instrumentation. I'm working in image processing for the last 10 years. That is, I'm working with the music project. I have not been still I have not completed a data of KD. I'm just doing all the AI methodologies in my presentation. Now, deep learning is what I'm going to do that we have deep architectures that are 3 layers of architectures, and they actually extract the features from very small part, 3 by 3 layer of the image, and then it is being trained step by step for each image. Then we extract those features and then we optimize those features which are the best features, like emerging detections, the 3D volumetric analysis, and then we have now we have another things that is extremely AI. It was previously what we used to see on machine learning libraries, but now if we say see this thing that is a computer system, they are black boxes. You have given inputs, then you have to follow. But when you deal with machine learning with extreme AI, they give you what are the features which are contributing exactly to the disease, and what are the complications, what are the risk factors, what are the strategies which shall be followed, which are contributing more to that. They can actually give the percentages of the contributing factors. Then, if we mix these up, or we test all these factors, then we have much more better diagnosis.
Yes. Thank you, sir.
I think we conclude this presentation. Thank you.
Thank you, sir. So the next couple of topics would be on the burning topics of today's world, artificial intelligence. To chair the first session, I invite Dr. Rakesh Kumar Pilania. He is Associate Professor of Pediatric Allergy and Immunology Unit in the Postgraduate Institute of Medical Education and Research. He has published more than 100 papers in peer-reviewed international and national journals. And his key areas of interest are Kawasaki disease, pediatric lupus, and inborn errors of immunity.
पानी पहले गई पता नहीं